Good evening. Welcome to the End of Life in Primary Care webinar series. I acknowledge that we're meeting on Ngunnawal country and pay my respect to the Ngunnawal people as the traditional custodians of the land in which we're meeting. And I also pay my respect to any First Nations people that are attending the workshop this evening. So welcome to number 5 of our End of Life in Primary Care webinar series. Tonight we are focusing on the symptom management of breathlessness. So we are going to first focus on the non-pharmacological management and then the pharmacological management for palliative patients or those people suffering chronic breathlessness. A couple of housekeeping points is there is a Q&A box for you to ask any questions, and also the meeting chat box where please feel free to introduce yourself, where you're from and what clinical setting you're from. You will also receive a survey which we would love you to complete so we can understand what works well and what your learning needs are when you're supporting your palliative patients in the primary and community care setting. Also, please note that this session will be recorded and you will receive a link to the recording, which will be on the CHN YouTube channel. Keeping in mind that for this session, it will be only up for a limited amount of time due to the fact that, particularly around the pharmacological management of breathlessness, it is changing month by month and we don't want to keep out-of-date information up on the website. So we haven't decided on the expiry date, but if you want to review it or share it with people, you will have a limited time to do that. This is number 5. We have 2 more sessions to go, and leading up to the introduction of voluntary assisted dying. The aim of this series was to cover aspects around supporting patients as they approach end of life. So thank you for joining us this evening. Firstly, presenting on the non-pharmacological management of breathlessness, I would like to introduce Mary Roberts. Mary is a clinical nurse consultant in respiratory ambulatory care at Westmead Hospital. Mary is a clinical senior lecturer at University of Sydney and a clinical fellow at UTS. Thanks so much for joining us, Mary, and I'll hand over to you. I'm going to stop sharing my screen now.
Thanks, Ros, and I'm going to try and share my screen, and please let me know.
That's currently on. Okay, wait. Yep, perfect.
Okay, so you can see what I'm presenting?
Yes, we can.
Excellent. Okay, so please put your questions in the chat. I can't see it, but if there's something that's jumping out, Ros, please feel free to kind of interrupt me and stop me if there's a burning question. Otherwise, we can wait till the end. So first I'll introduce you to another Mary.
It's a terrible feeling. You can't get your breath, and it takes about 5 minutes to really settle down again. When I exert myself, I always get short of breath. I couldn't do what I used to do, like what took me 5 minutes to do before, it'd take me a couple of hours to do, like changing the sheets on the bed and hanging the washing out and doing the housework, and I can't do a lot of that anymore. It's very hard to do things when you can't breathe,
So what is breathlessness? And I think that it's really complex, and we're probably where pain was, 10 or 20 years ago. So we know that breathlessness just isn't one thing, and it's a complex phenomenon, and it has at least 3 dimensions. So we've got that sensory perceptive dimension, which is how bad is it? the affective and the emotional response. So how unpleasant is it? So how bad is it? You can run up a flight of stairs and it will be really bad. But is it unpleasant? Does it cause you distress? No. But for somebody who lives with chronic breathlessness, that emotional response can be huge. Last time I got this breathless, I ended up in intensive care. So then they get all the fear and thoughts about dying throwing in their mind. And then the third dimension that we have to keep in mind is that impact on daily functioning. And these dimensions interact in these vicious cycles. So if I don't like that unpleasant or distressed feeling, I'm going to stop doing things. But the less I do, the less I'm able to do. So it becomes this downward spiral. And then we also then get these panic attacks that are quite associated with breathlessness, where people will call the ambulance. Look, there's lots of different outcome measurements about breathlessness, but none of them are comprehensive. So it's a really difficult symptom to get a hold of. I think it's really important that we acknowledge breathlessness. But just don't say to your patient, "Are you breathless?" Because they're going to say no, because they've maladapted their activities. You might want to say, "Are you troubled by breathlessness? What makes you breathlessness?" But what I think is the biggest question to ask is, what have you stopped doing to prevent breathlessness? Remembering they're sitting at home waiting for a home visit, or they've been sitting in the waiting room in the doctor's surgery waiting to go in. So they don't look breathless, they're not breathless. But if you ask, what have you stopped doing? Then you might hear, "Well, I only shower once a week. I don't go shopping anymore." Are you breathless now? No, but I've stopped all these things. And of course, then, you need to work out, is their breathlessness proportional to their pathophysiology? So has anything happened? Has anything changed? So if it's an anticipated change, that it's a slow deterioration, it's probably just the disease trajectory. But remember, patients come to you with multiple comorbidities, and it doesn't mean that just because they've got lung cancer that they haven't now developed a PE or a pleural effusion. So we've got our treatable, reversible extra causes, as well as the complex disease, which may be optimally medically managed. So I suppose a lot of people ask me, so how do we assess breathlessness? Is there a tool that we can have? And looking through the literature, I found 41 different measures. Do any of them work in every situation? No. We've got unidimensional measures that just, the single item scales. We've got the multi-dimensional measures, which are great for research, but really not practical in a busy clinical situation. And I think you have to choose your assessment based on what you want to do. And as I said, my main assessment tool is, what have you stopped because of your breathlessness? So I said that breathlessness was this really complex interplay of symptoms. And I love this diagram from Sarah Booth. And Sarah Booth was saying that breathlessness is not just about hypoxemia, or it's not just about the lungs. The brain gets messages from the lungs saying, "I need this much ventilation to meet my demand." And that message sent to the brain is basically from the central and peripheral chemoreceptors, the metaboloreceptors. But then there's feedback on the actual breathing. So the lungs say, "I want this much," and the brain processes that and says, "Okay, I want this much. How much am I actually getting?" And if they don't equal, that's when you get the sensation of breathlessness. But on top of that, as well as getting these feedback into the brain stem, we also get feedback from the association cortex and the limbic system. And this is where the mind plays a really huge part in breathlessness. So you've got those abstract thoughts of going on, of what's happening, but the emotional feedback, and it's, what's going to happen? Am I going to die? Am I going to have a heart attack? Last time this happened. And basically, your body says, "I want that red Ferrari," but you're giving me this junky car. I'm breathless. So what we want to do is get those two cars to be the same. And Sarah Booth went on to say, to summarize that complex diagram, is really breathlessness is fed in by 3 different cycles. So there's the breathing cycle, and that's really based on the use of accessory muscles, the chemoreceptors, how much that work of breathing they're having. And so that will feed into the brain to say how breathless. You've also got that functioning cycle, and that's that maladaptation of activities to avoid breathlessness. The less you do, the less you're able to do. The muscles become weaker, their oxygen demand is higher, everything takes that much more effort, so you get more breathless. And then we've got this thinking cycle, and that's really that the thoughts about dying, the thoughts about what happened last time I got breathless, and that adds into that anxiety and distress. And the more anxious you are, the more breathless you get, the more breathless you get, the more anxious you get. And so then you get this upward spiral. So we really need to try and treat all of those three vicious cycles. And I'm going to talk about the non-pharmacological interventions. Why have I chosen to do non-pharmacological interventions? I run a breathlessness clinic, and we set it up to do 8 weeks of non-pharmacological interventions. And then we thought we'd re-evaluate them at the end of 8 weeks, and probably 50% of them would still be really breathless, so we'll put them on pharmacotherapy. Pleasantly surprised, and we're about to publish our RCT, is that probably 95% of our patients got better just on non-pharmacological intervention. So these don't have side effects. So really important to try your non-pharm interventions first. So this is this is from another article from Sarah Booth, the non-pharmacological interventions for breathlessness. And I've split up the different techniques that you can use based on those three vicious cycles. And the ones that I've bolded are the ones that you can really do easily yourself, no matter where you work. So you don't need to be a breathlessness clinic. You don't need to be a palliative care physician. You don't need to be working in an acute hospital. These are things that you can do really simply and can make a huge difference to your patient's suffering. So the first thing you need to do is say to your patient, what goes through your mind when you get breathless? And it's really interesting because they're going to say, I have to stop everything. If only I had oxygen, I'd be okay. I'm going to stop breathing. Breathlessness is doing me harm. I'm never going to catch my breath. I'm going to die. I'm going to have a heart attack. And the first thing I say to my patients is, although breathlessness is distressing and it's horrible, it ain't going to kill you. Now, there's some nuance to that. So some things that cause breathlessness can kill you, and you need to treat the causes. But your normal everyday breathlessness that you get from making your bed, from walking out to the letterbox, getting changed, washing your hair, that's your normal breathlessness. It's distressing, it's horrible, it sucks. It's not doing you harm, you're not going to die. I've been working in health for, I think, 38 years. I have never seen one person die in the middle of a breathlessness attack. If it's their normal chronic breathlessness, we need to tell patients that, because every time they get a breathlessness attack, that's what they think. And their carers, their partners think that. So really important to dispel myths. I said that patients will often say, if I get oxygen, I'll be fine. And we can't give oxygen to everyone because often they don't qualify for home oxygen. But what's really important to understand is oxygen does not cure breathlessness. It makes us feel better if we give it to a patient. I'm doing something. There's been some really good studies to show that breathlessness is not reduced by oxygen. So a great study by David Currow, and what they did is a randomized double-blind control trial where they gave patients nothing, air, and oxygen, or via an oxygen concentrator, and asked patients to write down how much they could do each day and how breathless they were. So with nothing, really breathless, can't do anything. With air, they didn't know it was air coming out of their nasal prongs. I could do lots more and I'm not breathless. Oxygen, I can do lots more and not breathless. So it's the cold gas, not the actual gas itself. And I've got two pictures here, and I just completely off topic because I love going off topic. We've got a stationary oxygen concentrator and a portable oxygen concentrator. They are very different, other than the obvious difference. One's portable and one's stationary. But the stationary one at the top plugs into the wall. It's got a flow meter, and 2 litres equals 2 litres. The portable oxygen concentrator that the young man is carrying, you dial it up 1, 2, 3, 4, 5. But they are not litres per minute. They're psh, psh. They're pulse doses of oxygen. And 2 does not equal 2 litres a minute, and you really have to titrate portable oxygen concentrators using a pulse oximeter. Usually you have to double the pulse dose to equal litres per minute dose. So if they're on 2 litres of oxygen via continuous oxygen, they need a pulse dose of 4 to get about the same amount of oxygen. Just a quick little tip if you're not sure of that. So there's that article by David Caro's group. Amy Abernathy was the first author on that, and that's the effect of palliative oxygen versus room air on the relief of breathlessness. There was also a really good Cochrane review from Magnus, who basically said that oxygen can modestly reduce breathlessness given during exercise, but everyday activities, it doesn't actually improve everyday activities. And you have to think, sometimes if we give people oxygen that don't qualify for it, if they're not hypoxemic, they actually feel like they're tied to it. They don't go out, they don't live their life. And I'd rather my patients get out there and make the most of what time they've got left rather than sitting by an oxygen machine. So what can we do for breathlessness if oxygen doesn't work? And I think we need to do some breathing techniques, and we need to do some positioning. So when someone gets really breathless, what we want to do is we want to stop them doing that hyperventilation, that really, because all they're doing is really just moving a lot of dead space from the top of their chest. So you really want them to breathe from lower down from their diaphragm. And I often say, put your hands on your tummy. When you breathe in, you should feel your hands go out. When you breathe out, your hands should go in. So your tummy should go up and down, not your chest. Positions when you get breathless. I think patients will often go, I get breathless and I rush to finish it. I give them that analogy of the tortoise and the hare, go slow and steady. When someone is breathless, what you'll see is the shoulders will go up, they tense up. If they raise their shoulders, that means their accessory muscles are holding their shoulders up. They're not using their accessory muscles to breathe. So really important to try and get them to drop their shoulders down. So rather than that, get them down. The best way to do it, I don't know if you can see me, but leaning forward, dropping your hands between your legs, that helps drop the shoulders. It allows my tummy to drop down if I've got a bit of a belly as well, and then gives my diaphragm room to move. If they're not near a chair, it's leaning on a wall, leaning over a bench can help. And then I've also got some couple of little positions that people can use to sleep with as well if they get breathless at night. I said that often patients they want to get the air in because they're breathless and they think, I need to get air in. But often their lungs are hyper expanded, or they've got fibrosis and they're really tight. They can't get air in. So what we say is concentrate on the out breath. The in breath takes care of itself. And often I'll get them to breathe around the rectangle. Now, this was first designed for people with obstructive lung disease, and they were hyperinflated, and that long breath out was to reduce dynamic hyperinflation. But what we have found, even with our other patients who aren't hyperinflated, breathing around the rectangle is a really good diversional therapy. So it's stopping that little voice in the head that says, I'm going to die, I'm going to have a heart attack, and I'm concentrating on a rectangle. And what I'll say to my patients is, there's rectangles everywhere. So if you walk to the toilet and you're really breathless, look at the mirror. It's a rectangle. Look at the bathtub. It's kind of a rectangle. The shower screen, it's a rectangle. Breathe in through the short edge, breathe out through the long edge. So you're really diverting that mindset. I cut this out and put it on people's walkers, at their bedside table, anywhere where they're going to get breathless, and just get them to concentrate on breathing around the rectangle. Handheld fan. I think I'm talking to the converted here, that a handheld fan, cold air blowing on the lower half of the face, actually stimulates the trigeminal nerve, reduces the feedback to the brain, and basically says you're getting enough air. And it will help stop that hyperventilation. Fans are great. They're simple, they're portable, they're inexpensive. We're getting a new one out from the Lung Foundation, which goes around the neck. So it's actually hands-free. So people can have it aimed at their face and they can lean forward, they can use their four-wheel walker, they can do other things with their hands. Really important to explain to patients that a fan is not a gimmick, that there's actually really good medical evidence that fans work. And I've got their warning, not all fans are equal. You don't want to send them to a $2 shop and they buy a crappy fan, because if it's not the right speed, they're going to think that you're full of rubbish and that you're telling them a furphy. So you want to point them in the direction of a fan that has good airspeed and that's quite directional on the lower half of the face, and explain to them that they can use it in winter and summer. So even, you know, in the cold Canberra winters, you can have your scarf wrapped around your neck, you can have your beanie on, just blow that cold air on the bottom half of the face, Bob's your uncle. It actually reduces breathlessness. I'll just play a little bit of this video. This kind of explains how the fan works. If I can get the video to work. Magic of the internet.
Being breathless is disgusting. It's the worst feeling you can have in your life. Takes ages to have a shower or a bath. It's just because of the way my breathing is. I just don't have a choice. I do what I can do, and that's all I can do. But it is still the worst feeling you can have in your life. I can honestly say that.
Chronic or persistent breathlessness is a frightening and disabling symptom. Although it cannot be cured, there is still a lot of things we can do to support people to manage their breathlessness. The Breathing, Thinking, Functioning clinical model shows how different approaches can be integrated to address unhelpful breathing patterns, emotional and cognitive drivers, and the vicious cycle of deconditioning and social isolation, which are all features of this disabling symptom. There is high level of evidence for a range of non-pharmacological strategies, including breathing techniques, pacing and positioning, anxiety management, and physical activity. But the most simple and effective thing that we can do is offer patients a handheld fan. So you get the patient to turn the fan on and incorporate breathing techniques at the same time. So you want them to move the fan across the bottom half of their face so they get the airflow, and then they can incorporate breathing techniques such as breathing around the rectangle or concentrating on the out-breath. So they'll be going. This will enable them to catch their breath quicker and control their breathlessness in a more rapid way.
Recovering from breathlessness is what the fan helps you do. It makes you relax and gets your breathing back into line. And that's the most important thing.
Research about the fan is still ongoing, but what we think about the mechanism is that there are at least 3 ways in which the fan helps people with breathlessness. The first is that the fan stimulates the trigeminal nerve, particularly the 2nd and 3rd division, and then that signals the brain to say you're getting more airflow, more ventilation than you really are. The second is that the fan seems to increase expiratory time, and this then reduces dynamic hyperinflation. By reducing dynamic hyperinflation, it delays patients getting to the point where they can't take in enough tidal volume to meet their requirements when they're exercising. And this seems to be a very powerful mechanism for a lot of patients. Reducing dynamic hyperinflation allows people to exercise longer and to exercise more, thereby building their muscle mass, which helps to reduce breathlessness, again, by a different mechanism in the long period of time.
If I have a really bad attack, I have to use the ventilator and the fan.
But I won't keep going on because I don't want people falling asleep. We did do a study looking at the implementation of battery-operated handheld fans, and what was really interesting was everyone thought it was someone else's job to introduce it. So the Palliative people thought that the pulmonary rehab people, pulmonary rehab people thought the respiratory physician would do it, or, you know, I think it's everyone's job. So as long as we ask patients if they've got it, if they've tried it, really, really important. And realise that it really has no side effects. So it's a great tool to try. As I said, not all fans are equal, and we want to get something that has got enough airflow and still stimulates the face about 30 centimetres away. Don't want it too cold, too blowy, because that's unpleasant. The other thing that we need to do is really, so that was, I'm talking about those things that I just spoke about was the breathing cycle. I'm now talking about the function, the thinking cycle and cognitive behavioral therapy. No, you don't need to be a clinical psychologist for this. If you've got one and you can refer through the mental health scheme, please do. But otherwise, it's really just talking to patients and working through their unhelpful thoughts. So, you know, if I get breathless, I'm going to have a heart attack, I'm going to die. Okay, you got breathless yesterday. Did you have a heart attack? Did you die? Not. We want to get them to do that small acts of bravery. I can't go out. Okay, let's just walk to the front door today. That's all I want you to do. Don't go outside, just the front door. Tomorrow, one step outside the door. I think that patients will often go, yeah, I'm going to look funny using a fan. People are going to look at me. And I just tell patients, no one's looking at you. Everyone's walking around looking at their mobile phone. They're not looking at you. So, you know, what would you tell your friend if you knew that a fan would help them and they were too embarrassed? What would you tell them? And if you say that to the patient, then they're kind of a little bit more gentler on themselves. We need to talk to them about what they do for their panic attacks, and we've got a breathlessness recovery plan that I'll show you at the end of this talk. But it's stay in the moment. Don't think about what might happen. Let's just concentrate now on dropping those shoulders, leaning forward, blowing out, getting that cold air on your face. Patients will often say that I can't sleep because I'm so breathlessness. We know that if they're overtired, their breathlessness is going to feel worse. So even encouraging relaxation, and there's lots of good apps now that do relaxation. So you can actually click on an app and, you know, just get your thoughts taken away. And even that relaxation kind of recharges the battery and makes people less breathless. Of course, promote sleep hygiene, and I'm forever telling people no screens in the bedroom. Don't watch the TV, don't watch your iPad, don't do that. It's when you go to bed, go to sleep. You know, don't have alcohol, anything like that, you know, after about 6 p.m. The really big thing is when we go to the functioning cycle is we need to promote physical activity. And that's even with our palliative care folk. We know that patients feel better after exercise, and it can be graded exercise. So exercise can be just walking and turning the TV on and sitting back down rather than sitting and using the remote. It can be walking to the kitchen and getting their partner a cup of tea rather than the partner waiting on them hand and foot. So that extra little bit of physical activity can turn into exercise. And we know that that reverses the deconditioning cycle. The more they do, the more they're able to do. And I know that the palliative, the pulmonary rehab team at Canberra are great, and they do a lot of breathlessness training in their program. So if you can refer to the PAL Care team, please do. All of their staff have been trained in the management of breathlessness. So really, really good idea. If you don't know who your contact person is you can go to the Australian Lung Foundation website, type in pulmonary rehab, and they've got this search tool where you just put in pulmonary rehab, put in your postcode, hit search, and it will give you a list of pulmonary rehab programs near you and who the contact person is, so how to refer, which is really good. Really confuses patients because on one hand we're saying be active, but then on the next hand the OT is going to say you need to conserve your energy and rest. And the way that I explain this to patients is we want you to exercise so you're fitter so you can do more, but we also need you to save your energy so that you've got energy to do the things you want to do. So save your energy on the things you have to do, like showering, washing, hanging the washing out. So take shortcuts. But that way you'll have enough breath, enough energy to go and play with the grandkids, you know, get dressed up for a date night or whatever. So it's about that whole balance and really explaining to patients on a good day, don't go boom, because then you go bust and you'll have a really low day the next day. We want to keep activities, you know, pretty stable. And often what I will talk to patients about, you've got a jug of water, that's your breath. If you have a shower and you're standing up, you're going to use half a jug just to have a shower because you'll be really breathless. If you use a shower chair, leave the door open so there's low humidity and not a lot of steam, you will actually only use a little bit of that water out of the jug. So that's the way you do it. So the other really keen thing that I tell my patients is use walking aids. Patients hate walking aids. They make me old, I'm frail, I don't need it, I'm not risk at falls. But what I say to them is, okay, when you go shopping, who pushes the shopping trolley? It's the breathless person, because pushing a trolley actually allows you to walk further and faster. You can't take the shopping trolley out of the car park, you'll get fined. You can take a four-wheel walker. So just giving them that idea of, hang on, yeah, I can go to Bunnings and I push the trolley and I can do the 10 aisles. Maybe I do need a walking frame. Shower chairs, patients hate shower chairs. I feel I'm old. No one's going to know. Who cares? You know, use it because you'll have enough energy to do the things you want to do. Really good thing is when patients get breathless, they come out of the shower, they're dripping wet, trying to get a towel to wash themselves, they actually get more breathless because they're using their upper limbs, which will make them more breathless. I tell them to go to IKEA and get a bathrobe. You wrap that around them straight out of the shower, wrap it tightly and sit down. And what that does is that dries them. Then they just need a little hand towel to wash their wipe their face and their feet, and they're done. So as my patients say, bathrobes, simply the best, because all of a sudden now they can have a shower and dry themselves. They don't need their partner to help. Of course, if you've got an occupational therapist, refer them, because they have lots of cool aids helping them get in and out of cars so that they're not breathless, sock putter-oners, long-handled shoe horns. They're amazing. They've got all these gadgets, so please refer to occupational therapists. There's some evidence about complementary therapies, acupressure, aromatherapy, massage. I think there probably needs to be a little bit more research about it. I don't promote this in my clinic, mainly because I can't do it and I can do all the other things, but there is some emerging evidence, so keep an eye out for that. Patients will often complain about breathlessness at meals. If people lose weight, they'll get more breathless because they lose muscle mass. So I encourage patients to choose easy to eat meals. So rather than the T-bone steak that takes effort to, cut it and then effort to chew it, use soups, stews, fish, stuff that's a little bit more softer on the palate that slides down easily. Frozen meals are great when you're not feeling well. You whack them in the microwave. It just cuts down on that preparation so that they're less breathless. And of course, if people are losing weight, I get them to pimp meals. You can't tell a patient who's breathless to eat more, because filling up their tummy pushes up on their diaphragm and they just feel uncomfortable and they won't do it. So what I say is, okay, if breakfast, you have your baked beans, okay, 230 calories. If you put some grated cheese on it, you're still only having that piece of toast with baked beans, but with the margarine and grated cheese, we've increased the calories by 60%. I'm not forcing you to eat anymore. Lunch, instead of a cheese and ham roll, add some avocado and some mayo, and all of a sudden we've almost doubled the amount of calories, still only eating that one roll. So it's about pimping meals, getting them to eat more dense food rather than lots more food. So, and again, as I say, refer to a dietitian if you have access, but otherwise some simple tricks like this really work. These are in a crisis. If patients are having a panic attack or having a breathing attack after they've just done something, they've had a coughing fit, you get them. I've got 4 of these in the moment breathlessness rescues. So this is breathing around the rectangle, print it out, give it to them. And it's just that slow breath out, short breath in, long breath out. Oops, wrong way. There's the 3 Ps, which is pause, position, purse lip. So stop what you're doing, get into a position that makes it easier to breathe, purse your lips, and that just stops that hyperventilation. So it's, once again, purse lips was designed more for your obstructive lung disease. But what we've seen is even in our fibrotic patients with restrictive lung disease and cancer, that often they'll do the purse lip, and it's more just to stop the hyperventilation. So it works. The 3 Fs, my men like this. I think they think that the F stands for something else, but it's I'm going to lean forward. I'm going to use my fan. I'm going to focus on breathing out. Can you see how all the plans are saying the same thing, just in different ways? Stop, drop, flop. Stop what you're doing, drop your shoulders, flop forward. So we're saying the same thing, but it's just how to catch your breath back quickly after you've exerted yourself. And this is a new plan that we're designing with the Australian Lung Foundation at the moment. This is a co-designed breathlessness action plan. So it's been designed by patients, carers, healthcare professionals, and academics. And what we've done is we've got all the evidence, but we're now testing it out with patients and working out what to do. And what we're encouraging patients to do is to do your 5. So stop what you're doing, think, get rid of those bad thoughts, position, get into that lean forward position, breathe out slowly, and get airflow, and then take back control. And we're just saying those 5 steps will often stop that whole breathlessness attack. And of course, at the top there, it says number 2, if they don't get their breath back within 10 to 15 minutes, that they then have to seek medical help. Remember, look, I'm talking to the converted here. You guys all know this. But there's a huge impact on carers. You know, it's heartbreaking when the person you love can't breathe because you can't breathe for them. So really think about your carers. They live with it 24 hours a day. So we need to support them as well. There's this really great website, and this is from the UK with Morag Farquhar. And she interviewed all these carers and asked, what do you want to know about breathlessness? And they came up with these 6 points. And this is a great website where you can actually download and give handouts to your carers, because often they're a little bit too scared to ask in front of the patient. So fantastic website. There now, breathlessness intervention service. You've got one in Canberra. That had some really positive results that Roz has probably shared with you. But this is a meta-analysis, and it's looking at holistic services for chronic breathlessness can reduce the distress in patients with advanced disease. And they basically looked at all the studies on breathlessness intervention services. These are services that usually promote non-pharmacological interventions. And as you can see, not only does it reduce the distress in breathlessness, but it improves mastery, that self-confidence that they can manage breathlessness, and reduces anxiety and depression as well. So really good. And these are just 2 great papers. One of them's mine, I shouldn't say 2 great papers. 2 papers summarising some of the different breathlessness clinics that are around. But all the things I've just spoken to are what we use in these breathlessness clinics. So you don't need a breathlessness intervention service. You can do it yourselves. And this is just a summary, and I'm sure that Roz will point you to the page, but this is a breathlessness intervention service that we helped run in Canberra as a pilot program, and look at those results. Pretty darn exciting. But as I said, a lot of the learnings from this have actually been taken on by a lot of the healthcare professionals running pulmonary rehab and some of the PAL care units in Canberra. So really exciting that one little project can spin off and I suppose empower lots and lots of clonicians. If you are a nerd and you like reading, I love this book. Once again, I've got a girl crush on Sarah Booth. She's she's passed away now, an amazing clinician, but she wrote this book on managing breathlessness in clinical practice, and it has all those really easy tips that anyone can intervene. If you want extra information just on the respiratory diseases, I'm a respiratory CNC. So there's the chronic obstructive pulmonary disease clinical care standard. There's lots of different standards that now GP practices have to meet. One of them is end-of-life planning and symptom management. That's 9 and 10 of the clinical standards. So you can download that from the Australian Commission on Safety, Quality and Healthcare. And there's also a really good book from the Australian Lung Foundation, Transforming the Agenda for COPD. And it's really about stopping the discrimination of care between postcodes. And then if you're interested in the ILD patients, I think we're getting a lot more of these. And with lung cancer screening, you'll probably come across a lot more incidental findings of pulmonary fibrosis. So there's some really good resources on the Lung Foundation website and some for the real nerds, if you want to learn more about interstitial lung diseases, these books from the American Thoracic Society. More than happy if anyone wants to reach out and ask me to send any of these resources to you to read. More than happy to email them to you. But I'm going to stop sharing and let Sarah take over. Hopefully I haven't gone over time.
Thanks, Mary. Before we hand over to Sarah, thank you very much. Any questions from people that have been listening to Mary's very quick introduction to the non-pharmacological management of breathlessness? So Mary provides training that can last 1 to 2 days. So it was a really big challenge to for Mary to fit all of that into 40 minutes. So hence why I've been posting things in the chat as we're going along. So any questions before we hand over to Sarah, or any resources in particular that Mary mentioned? I will pop Mary's email in the chat. Is that okay with you, Mary?
Of course it is. Yep.
Yeah. So any questions?
Is anyone awake?
Yes. Are you awake out there? I guess they are. Yep, they are.
Oh,
Excellent. Great. All right. Well, thank you, Mary, for coming in to speak to us. Please hold on because questions may come up as we go along. So I'd like to now introduce Dr. Sarah McPherson. Sarah is a palliative care staff specialist at Clare Holland House. Sarah currently works in the community part of the service in the home-based palliative care team. So working closely with the patients that are still sitting in the primary care space. And amongst other things, Sarah has a special interest in the management of breathlessness of patients that are approaching end of life. So Sarah has kindly put together the pharmacological presentation of the management of breathlessness. Now, whilst this workshop is under the palliative care banner, as Mary has presented, she doesn't work specifically with palliative patients. She has been working, her space is with patients that suffer persistent or chronic breathlessness. Moving into Sarah's presentation, it is much more focused on the palliative care space. So keep that in mind. Anything that Mary spoke about is for all patients suffering breathlessness, and Sarah is more particularly around palliative patients. Thanks very much, Sarah. Handing over to you.
Thanks, Roz. I'll just try and share my screen.
Please go ahead. We've got it.
Yeah, it work. Can you hear me okay?
Yes, we can. Thank you.
Perfect. Thanks everybody coming to listen to the chat about pharmacological management of breathlessness. Unfortunately, the kind of the data and the meta-analyses and all of the information that we have about managing breathlessness from a pharmacological perspective, it's not very black and white. So it just makes it a little bit tricky about what we do for a lot of patients. So I was just hoping today to sort of speak through a little bit of the evidence for managing breathlessness from a medication perspective, and what patients might be appropriate and other patients that might not be as appropriate, and then hopefully that'll be useful in terms of applying it to your specific clinical context and the patients that you're seeing in clinic. I can get my slides to work. So, in terms of the things that I'm going to talk about today, I think most people are kind of aware that for symptomatic management of breathlessness, the most common things we tend to use are opioids. We might use some benzodiazepines in combination, oxygen, which we've already talked about a little bit. And then part of this is also managing the symptoms that come along with breathlessness and might also worsen breathlessness. So, in particular, I think it's really important that we try and manage cough as well. That's in terms of the symptomatic management. The other thing, of course, to improve the experience of breathlessness is actually trying to target the underlying disease process. And that depends on if it's malignant or non-malignant causes of the breathlessness. And I know it's already been spoken about already today, but certainly breathlessness is very subjective. Chronic breathlessness is often ranked by people with serious respiratory illness to be their most distressing symptom. And often it persists despite optimization of their underlying conditions, and patients who really are on maximal management of things like their COPD under their specialist lung physicians. They've had pulmonary rehab, and sometimes they're still breathless, and it can be really tricky to try and manage. It reduces their quality of life, and it's a little bit of a cycle. So patients become really fearful of becoming breathless, then they avoid exercise, and then they become deconditioned and they become socially isolated. As a result of this, we really need a good way to try and manage this breathlessness, particularly in non-malignant disease. And today I'll talk a little bit about both malignant and non-malignant kind of management of breathlessness. And to be honest, how we're going to do this, there's no straightforward answer, and a lot of it's sort of managing it based on the individual patient that's sitting in front of you and their specific needs. In terms of before thinking about starting medications, so certainly doing a really good symptom assessment is where I tend to begin, talking about the intensity and the distress as well as the functional impact of the breathlessness. We use something called a symptom assessment scale in palliative care, and it's not so much how severe is the symptom, but how much distress is your everyday life being kind of affected by breathlessness itself. What does it feel like? Is it a feeling of air hunger? Is it a feeling of suffocation, chest tightness? Is there anxiety? Is there panic? What's happening alongside this? And if we can try and get a bit of a number as a starting point from 0 to 10, then we can work out if the interventions that we're starting are actually effective or not in terms of managing that symptom. It's also really important that we assess and manage any reversible contributors. So a lot of our patients are anemic, they're iron deficient, they might have exacerbated their airways disease, they might have developed a PE. So it's really important that we screen and manage that, particularly for patients who aren't in those final kind of weeks of life. Optimizing their underlying conditions and comorbidities, making sure that we're addressing any psychological factors that are contributing to their breathlessness. Non-pharmacological interventions are kind of the cornerstone of managing breathlessness, and referring them to pulmonary rehab or tailored exercise program if appropriate as well. And certainly that's something we do at Clare Holland House for our outpatients. We have a little gym here, and the patients that are well enough tend to have quite regular reviews with our physios here. Very tailored approach to that, and maintaining their fitness as much as possible. In terms of managing breathlessness, most people kind of reach for opioids as their first point of call. Although for patients with chronic dyspnea who are not sort of in those final weeks to short months of life, the evidence is pretty limited. Although, to be honest, we still use it as a first line approach to manage dyspnea, because, to be honest, we don't have a lot of other options. There have been some new systematic reviews and meta-analyses in the last 12-24 months, which is likely to be practice changing, particularly for patients who have chronic non-malignant breathlessness. And I'm going to talk about those in a minute. We can consider adding something like a benzo, so whether that be lorazepam, clonazepam, if the patient has significant anxiety associated with their breathlessness. And the other thing that we worry about with things like opioids and benzodiazepines is their side effects can be pretty significant, particularly in patients who are frail, which are most of the patients that are needing these types of medications. In terms of the options for opioids, if that's something that you feel the patient would benefit from in terms of their breathlessness, morphine certainly has the most evidence. but the use of it's conflicting based on what the underlying cause of the breathlessness is. We tend to use quite a bit of hydromorphone in the palliative care space. Not so much codeine, although there is a little bit of evidence to support it. Fentanyl as well, conflicting data, and certainly there's no evidence to support the use of oxycodone or endone to manage breathlessness. We use different modes of administration. So most of our patients are on oral morphine, either long-acting or short-acting, or if they're really towards the end of life, we use subcutaneous opioids. There's no evidence to support inhaled opioids of any description. It's not something that we use in the palliative care space. And for those patients that have issues with swallowing and that are end of life, then we think about using a syringe driver with a 24-hour infusion of the subcutaneous opioids just to manage those symptoms. In terms of clinical considerations, there's a few different ways that you can start an opioid in someone with breathlessness. So, for example, one way would be preemptively prescribing an immediate release opioid, so something like short-acting morphine, half an hour before a patient does something that they know is going to cause breathlessness. For most of that patients, it's usually showering that really knocks them about. So that would be the first thing we ask them to start with. And if they're going to take it before they have a shower, make sure they've got some standby assistance. So we try and keep it as safe as possible. We can use it as required in an acute exacerbation of chronic dyspnea, although that we'd probably do less frequently if the patient's still having kind of ongoing active management of their condition. And then we can use regular therapy. So that's particularly useful for patients who have shortness of breath at rest or on minimal exertion. In terms of the starting doses that we might consider for managing dyspnea, we usually start really low relative to the doses that we'd use for somebody with pain. So 1 to 2 milligrams immediate release every 4 to 6 hours is required, or you could even do it sort of 4 times a day regularly. We might think about using something like a modified release morphine, so Capanol once a day, and can also use additional as required immediate release morphine on top of it. From the limited evidence, the maximal dose of morphine for breathlessness as a symptom, we usually wouldn't go above 30 milligrams over 24 hours, and that includes both the long-acting and the short-acting morphine, just because it's more likely to cause harm than it is benefit. Also, if you've got patients who have any sort of renal failure or if they've got allergies, hydromorphine is a good option, but it's only available in tablets. We can very rarely get it compounded in a liquid form, which makes the dosing a bit easier, but it can be quite tricky to kind of cut it into half or cut it into quarter when you're starting small doses because it is quite a potent opioid. The other thing to consider, particularly for your patients with sulfur allergies, is a lot of the morphine compounds have sulfur in it, so you can't use it in a lot of these patients. So that's just another thing to kind of consider. In terms of the underlying cause of breathlessness, that also influences whether or not opioids will be helpful for their breathlessness. So pulmonary hypertension, probably no benefit in giving an opioid for managing their breathlessness. A little bit of evidence support heart failure patients with opioids and dyspnea management, and ILD there's a bit more evidence. So depending on what the underlying cause is will also guide whether or not starting an opioid is a useful symptomatic option for these patients. In terms of how it works, so it certainly targets the feeling of dyspnea by acting on certain areas of the brain which are rich in opioid receptors. Probably also causes a bit of pulmonary vasodilation, but that's not really as significant in terms of how it works. And there's a significant overlap between the sensation of pain and dyspnea. And these two sensations are probably integrated together because a lot of the areas of the brain that deal with pain also experience that sensation of dyspnea and are involved in processing that sensation. And certainly endogenous opioids have impacts on breathing and its sort of sensations as well. So that's where that crossover happens. But thankfully we can use lower doses of morphine relative to that for pain when you're treating dyspnea. In terms of the evidence, this is where it gets really, really tricky. Several expert groups recommend using systemic opioids in patients with advanced terminal disease. But again, you've got to be really cautious about respiratory depression and side effects, particularly if it makes patients unsteady, the high falls risk, that sort of thing. Then you look at some of the other, so the European Respiratory Society, for example, their guideline actually recommends against opioids in patients with serious non-malignant respiratory disease, particularly because there's really conflicting results of studies for patients with COPD, which is usually the main patients included in these studies. The problem with a lot of these studies is they exclude patients with severe COPD. They kind of look at the patients with moderate disease, and they exclude patients receiving palliative care or have an active malignancy. And it's not uncommon for patients to have both COPD and an underlying malignancy as well. Clinical experience does suggest that opioids are beneficial at end of life in non-malignant end-stage respiratory disease. But really it's quite unclear in terms of the medium to longer term management of symptoms. There's been 2 recent systematic reviews and meta-analyses in terms of just looking at patients with chronic non-malignant lung disease, and this is patients with kind of a longer prognosis of many months to years. And to be honest, most of these studies have been quite negative in terms of using longer term opioids. Really, the only thing that they've found is that patients in the studies that they've used opioids, it's all been in exercise studies in labs, and that's certainly improved exertional breathlessness, but not the breathlessness that happens in their everyday life. The opioids didn't improve their cough, they didn't improve their quality of life, and they didn't reduce the sensation of breathlessness. And for most of these patients, it actually caused significant adverse effects, so particularly drowsiness, constipation, and vomiting. The studies that they included in this specific review were pretty reasonable in terms of the dosing that we would use in a practical setting. So using modified release morphine up to sort of 30 milligrams or 40 milligrams, or regular immediate release morphine as well. So it would be something that we'd actually use in a practice setting, but unfortunately it's been quite negative in terms of the results. Also, all the trials excluded the patients with malignant disease, which makes it tricky, particularly in a palliative care setting. And similarly, Lou et al. Found a very similar outcome when they did a systematic review, although initially they sort of felt that short-acting opioids were beneficial in breathlessness, particularly those with COPD. They didn't actually distinguish between breathlessness like in daily life versus exertion, and most of the studies that they included in their systematic review were those that tested the opioids in a laboratory setting, so it really can't be extrapolated to everyday life. And again, just kind of, so I don't want to bore you too much with studies and things, but there's been a couple of studies that have been positive and a couple of studies that have been negative, which kind of even muddies the waters even more. So there's the Mordic trial, which was done in 2020, and those patients actually had moderate to severe chronic breathlessness and COPD. And certainly those patients with severe COPD, so we're kind of looking more at those patients with a shorter prognosis, did have benefit from the long-acting morphine. But they'd also recently had pulmonary rehab, which is also impacting in terms of the benefit of the medications. And Abernathy similarly found positive outcome of slow release morphine with improved breathlessness and sleep. And those patients included in that study, again, had quite advanced disease, and I would consider to have quite severe chronic breathlessness related to quite end-stage disease, rather than those patients who potentially have years to live. The BEAM study, which is kind of on the opposite end of the spectrum, there was no difference in breathlessness, intensity, or ability to undertake ADLs. So they're all very conflicting in terms of is this helpful, is this not helpful? And I guess that's where the individualized approach comes in, and working out, if this patient has really got severe breathlessness, we've tried everything else, we feel like their prognosis is actually quite short, it's worthwhile giving it a go, accepting that the side effects are potentially quite significant, but some patients, they do respond well, and certainly clinical experience would show that. However, in a lot of patients who may have a longer prognosis, it's probably not a helpful thing to do. It's probably more harmful to start them on an opioid. In terms of opioids for breathlessness management in ILD, there's a bit more evidence to support using both long-acting or short-acting morphine in these studies. No benefit from inhaled morphine, but certainly kind of even in breathlessness in everyday life, it's likely to be quite helpful. And I guess the other thing that I take away from this is these patients tend to have quite severe disease, and by the time they're referred to people like palliative care, they've got quite severe breathlessness and they're heading towards that end of life trajectory as well. So it's probably why we're seeing a good benefit from that. And it's not really until the end stage of disease that they're getting prescribed opioids. In malignancy, certainly it's helpful to give opioids for management of breathlessness. And it's certainly superior to placebo. It can improve breathlessness, whether it's given orally, subcutaneously, and certainly improves breathlessness at rest. And you can use just regular morphine should be helpful. Less evidence for endone or hydromorphone in these patients, but certainly in our clinical practice, we use a lot of hydromorphone in patients with active malignancy, not just for their breathlessness, but also for their pain management. Just having a look at morphine and the sensation of air hunger is something that's a little bit separate. Certainly the sensation of air hunger seems to be quite responsive to morphine. But again, most of the studies that have looked at this have been in a laboratory setting, so it's really hard to extrapolate it to patients in their everyday lives. And usually it's like an infusion as well, so it makes it really difficult to say whether or not this is actually feasible to implement it in an sort of a day-to-day setting. But it's certainly something that probably needs to be looked into further about what the sensation is of breathlessness, if it's air hunger, if it's another type of sensation, and whether or not that'll actually respond better to opioids than other sensations. So the next thing I just wanted to briefly talk about is managing anxiety and how this can sort of contributes to the sensation of breathlessness. It's a natural response. If you're feeling breathless, you're going to feel anxious as well. You're possibly going to feel quite panicked, which is where the non-pharmacological management kicks in terms of managing that feeling and the response to feeling breathless, particularly when the patients are having intermittent attacks. In a palliative care setting, we certainly use benzodiazepines, not specifically for the breathlessness, but for the anxiety component of the breathlessness. There's been quite a few studies to show if the patients aren't feeling anxious and they don't describe feeling a level of anxiety with their breathlessness, you're likely to cause more harm than good if you prescribe a benzodiazepine for breathlessness itself. It's also worth considering treating like a comorbid anxiety disorder. So whether that be with SSRIs, with psychology input. In our service, we don't have a psychologist, but we refer to our social work team and or our pastoral care team as well, just to provide those additional supports for patients. And we've also got a psychiatry registrar who visits as well, who can also provide advice about managing this. Sorry, this is just summarizing what I've sort of already said, where essentially if a patient has breathlessness and they're not anxious, benzos aren't going to help. If they are anxious and associated with the breathlessness, then it's worth considering a short course of benzodiazepines, but certain wouldn't be something that's routine practice because of the risks associated with the benzodiazepine intolerance building up. I know we've already talked about oxygen prescription, but I guess I consider oxygen itself as a medication. It's not specifically a pharmacotherapy, but it's certainly something that's prescribed, and it, I guess, is only something that's prescribed in specific situations. So as we've already talked about before, the patients need to be hypoxic, otherwise there's no real benefit and potential harm in terms of prescribing oxygen. And we have reasonably strict criteria about who can have oxygen in the ACT. So ceasing smoking at least 3 to 6 months with no smokers in the home, making sure they haven't previously retained CO2. The oxygen tubing can be a significant trip hazard, and also patients that are on long-term anticoagulants that have can have severe nosebleeds with the oxygen as well. So there's little things that we need to consider before we think about prescribing it. The other thing that we can also prescribe, we were talking about this before we started actually, is prescribing a handheld fan, particularly for those patients who don't meet the criteria for home oxygen or it's unsafe, they're still smoking. A fan's a really, really good alternative in terms of managing that breathlessness and something that they control. And that's avoiding the risk of kind of giving them oxygen, which puts them at risk, the other people in the house at risk, that sort of thing. In terms of managing cough, that's another component I think is really important when managing breathlessness. So if they've got, for example, describing a cough with thick sputum, encouraging bromhexine, you can just get it over the counter, take it 3 times a day, and it can really help with just bringing up some of that phlegm and then reducing the breathlessness. You can also trial saline nebs as another option. If the patient has an underlying malignancy or they've got lymphangitis related to cancer, steroids can be really, really helpful. If they've got lots of secretions leading to cough, things like amitriptyline, glycopyrrolate, atropine drops can be really, really useful. So particularly atropine drops in the M&D population. They're actually the eye drops, but you give it under the tongue, and it's really helpful to dry up the excess saliva and reducing cough if that's causing the patients to have increased coughing episodes and then increased breathlessness. And then there's your usual culprits, so things like codeine or morphine to try and suppress the cough. Methadone can be really helpful at low doses, and so can paroxetine, particularly for patients who have a cough related to an introthoracic tumour. In terms of the novel agents that have been studied, not much evidence either. So cannabis probably doesn't do anything. Nebulized opioids definitely doesn't do anything. And helium oxygen is just not available. So really none of them are particularly good options in terms of managing breathlessness for patients that are in the community and needing that sort of additional pharmacological support. You're better off going with something like morphine that has some evidence rather than some of the other novel things that aren't quite as helpful. We all were hoping that mirtazapine might be a really good option to manage breathlessness, particularly in these patients where they've got longer term breathlessness and they're likely got a prognosis of years. But unfortunately, all of the studies that have been done have not shown an improvement in breathlessness, and because of the nature of mirtazapine itself, particularly drowsiness at night, appetite, that sort of thing, it is associated with significant side effects if you don't use it in the right population. So unfortunately, that's not improved breathlessness. And then just talking a little bit about some of the other things that we can do to manage breathlessness in the populations that we see, particularly in a palliative care context, is treating the underlying condition that's causing the breathlessness. So particularly I think patients like with heart failure, trying to diurese them as much as possible. So whether or not that's through a short-term subcutaneous furosemide syringe driver or oral bumetanide, just to try and get that fluid off so that they breathe a little bit more comfortably. And it certainly can reduce the edema as well, so they feel a little bit more comfortable with their lower limbs. They can be a bit more active and lose less muscle mass. In some small studies, using a longer term furosemide syringe driver is actually quite safe, even if you're not monitoring their electrolytes and their renal function, as long as they're being clinically assessed rather than doing bloods. It can be really helpful. In terms of COPD, optimizing everything that you can in terms of bronchodilators, steroids, whatever you need to do just to get on top of things. And then, as I sort of mentioned before, in patients with a malignant sort of obstruction of the airways or lymphangitis, dexamethasone can be really helpful in terms of reducing breathlessness. Although it's not going to it's not going to tend to work for a particularly long time. It can give significant symptomatic benefit for this group of patients. So in summary, the evidence is really mixed and it's really hard to make a recommendation. It's got to be tailored to the individual patient. There's certainly evidence to say morphine's useful in cancer-related breathlessness, but in terms of long-term use of opioids, particularly for patients with things like COPD, there's not a huge amount of evidence to say it actually helps with the dyspnea that happens in everyday life or with their ADLs. Towards the end of their illness, where they've kind of got a shorter prognosis, from my clinical experience, it can be quite helpful, and some patients do respond quite well to morphine, but I think you really need to choose the right patient for this, and we need much lower doses than you'd use for patients being managed for pain. Can use some benzodiazepines, but that is, again, would be very short term, and it would only be related to anxiety related to the dyspnea itself, not to treat the dyspnea alone. And also getting other people involved, whether that be psychologists, psychiatrists, to managing any underlying anxiety disorder. Oxygen supplementation can be helpful if they're hypoxic, but there are risks. Manage the cough if we can, and unfortunately there's no evidence to support use of mirtazapine, nebulized opioids, or cannabis for dyspnea management in the palliative care population. So really kind of leaves us with opioids and benzodiazepines for these refractory patients, but we just need to choose the right patient to be starting these medications off. And certainly in clinical practice, we'd only really give it a trial for maybe a couple of weeks to see if it works, and if it's not working, then actually wean them off and stop it, rather than continue on in the longer term due to the nature of the side effects. And I think that's all I've got.
Thanks, Sarah. Any questions for Sarah? While you're popping questions in either the Q&A box or the webinar chat, just a couple of things that I want to highlight that Sarah's spoken about is the use of existing bronchodilators. And I know Mary in particular is very careful to ensure that patients are using the bronchodilators to their maximum benefit, and not spraying them over their head or, not using them correctly. So Mary, jump in if you want to add anything more to that.
Yeah, definitely. I think that it doesn't matter how long your patient has been on inhaled medications, you need to check their technique. Up to 94% of patients do not use their inhalers properly, and unfortunately up to 85% of healthcare professionals don't know how to check inhaler technique properly. So I don't work for the Lung Foundation, but they've got some great videos. So if somebody's using an inhaler you've never seen before and you don't know if they're using it properly, go onto the website and you can actually watch. But for pressurized meter-dose inhalers and soft mist inhalers, they need to breathe in slow and steady over 3 to 5 seconds. So when they're using a puffer, it should be a breath in. So none of these quick squirts. And for dry powder inhalers, such as the Ellipta device and things like that, it's quick and deep over 2 to 3 seconds. How's that?
That's great, Mary. So great teamwork. So thank you for that. Another point I want to mention is your patients that are suffering chronic breathlessness, don't assume, and this is reinforcing what Sarah and Mary have said, don't assume if they're seeing a respiratory physician that their breathlessness is being assessed and responded to with best practice. So like I think, I can't remember if it was Sarah or Mary said, everyone thinks it's someone else's responsibility to assess the impact breathlessness is having on someone's life and then provide some management around that breathlessness. So please don't assume that with your patients suffering chronic breathlessness. The other thing, Sarah, I wanted to ask you is if the patients that are being seen in primary and community care space have a life-limiting illness and suffering intractable breathlessness, despite the interventions that GPs have tried, is it appropriate to refer them to specialist palliative care, or when might they do that? So these are patients that are not clearly imminently dying in the last few weeks of life, but perhaps have still got some time to live. How is best to manage these patients? Because what you've talked about, the nuances of breathlessness management, is huge around medication.
Yeah, thanks, Roz. So it's a bit of a tricky one, but to be honest with you, I think if it's causing a significant impact on their daily life, if it's causing significant distress, then it's always better to refer, and then we can see them in our clinic. So in terms of like managing that, it may even be that we're seeing them and then getting our physios, our OTs, everybody involved in terms of coming up with a multidisciplinary management plan. And certainly a lot of patients have been through things like pulmonary rehab, but it might have been some time ago. And sometimes it's about re-referring to other known sort of teams as well to get them involved. But it is quite helpful to get us involved. So then at least we can all not just work on the management of the breathlessness, but we can have conversations around advanced care planning, powers of attorney, that sort of thing, because these patients are going to deteriorate at some point. It's just when, and working out what their priorities are. So I think it's always a good thing to refer. And a lot of the time, we're not just going to jump in and kind of give morphine or that sort of thing. We'll generally refer to our allied health colleagues who are really experienced with breathlessness management. And I got an email this morning saying that we're likely to start a breathlessness clinic in our outpatient service in the upcoming months. So I'm hoping that that'll take effect soon. And we can kind of support these patients a little bit more as best as we can. We've got more social work and involvement as well in terms of we don't have a psychologist, but we've got people that can provide anxiety management strategies. We've got our physios to work through the non-pharmacological strategies, taking them to our little gym and doing that routinely or regularly. Is also really helpful. I've seen some patients who've been under our service in the outpatient clinic for years, and they're doing so well because our physios are supporting them significantly and keeping them as well as possible for as long as possible. And like you said before, I think a lot of these patients, it's wonderful they see their respiratory physician, and that's great. They're optimizing what they can. But a lot of the time people don't ask about how distressing is your breathlessness. They just ask how far can you walk before you have to stop. Rather than how much distress is this causing you? You're not sleeping because you're worried you're not going to wake up, or whatever the situation might be. And I guess that's where we can get involved, and we can be helpful in managing and talking through some of that. But a lot of patients also have a lot of fear around dying with end-stage lung disease and potentially suffocating. So talking patients through how things might go towards end of life, even if they're quite a way away from it, can actually be really helpful. So it takes the stigma away, and there's less fear around that.
Super. Thanks, Sarah. And so just re-emphasising the impact of the non-pharmacological intervention and reflecting on the pilot that we've just completed in ACT, we had 140 patients participate in that pilot. Every one of those improved in one outcome measure and their quality of life. Of those patients, 1 in 5 thought about calling an ambulance or didn't on 46 occasions because of the skills they had learnt in self-managing their breathlessness. So we have some ACT data to prove the benefits of non-pharmacological interventions. Now, on health pathways, we've updated the referral forms for into specialist palliative care for patients with life-limiting illness. Doesn't mean home-based care, or it doesn't mean inpatient. Please know that there is an outpatient clinic there. And what Sarah's just said is that outpatient clinic has access to medical support, but now also a multidisciplinary support as well. Also, the palliative care symptom management pathways on health pathways are currently being updated. And I just jumped on and had a quick look at the breathlessness tab, and that is a bit out of date. So this is how quick things change. So our aim is to review all those pathways by the end of December, and the breathlessness one should be updated by then. I think that's everything. Have I missed anything, or is there any questions by anyone? Have you found this helpful to your current patient cohort is the question. Is there a recording of the webinars and how to view? I missed last week. Yep, there is. There will be a recording of all of the webinars on the Thanks Canal on the CHN YouTube channel. And I'm excited to say that they've all been really good quality and we've had huge engagement. So it will be uploaded in a couple of days. Thank you. And Mary has agreed to send out a PDF version of her presentation. Thank you, Mary. Great. With Sarah's presentation, I'm going to make the decision that we're not going to send that one out, Sarah, just because that it's not clinical advice, but it's an overview of what's happening. Sarah, do you want to elaborate on that, or what are your thoughts on that?
Yeah, I guess that if we could maybe even send out some of the recent articles, that might be a bit more useful, only because things are changing, and I think the scope of managing breathlessness, particularly in a palliative care context, has changed significantly even over the last 12 months. But in terms of there's two particularly recent articles from the last 12 months. It's the most useful thing to probably read through and just work out whether or not your patients, fit that bill, and whether or not we should use morphine or not for this specific clinical context.
Yep, super. Okay, great. So Sarah will send through to me the most relevant articles. Mary will send through to me a PDF. Any other questions? And there will be a recording of all our sessions on the CHN YouTube channel. Thank you. Any questions or comments? We're getting lots of claps and thanks and celebrations, noting that it is Diwali at the moment as well. So thank you everyone for joining. We really appreciate it. We appreciate your interest in supporting your palliative patients, and we look forward to seeing you next week. Next week is session number 6, which is on completing certification of death in the community. We've had lots of feedback from GPs, particularly new GPs, that this is something they're not confident in doing. We've got the forensic medicine team coming to present on that and talk about which cases may be referred to the coroners and which may not, and then the practicality around completing death certificates. So we look forward to seeing you next week. Thank you, everyone, and have a good evening. Bye-bye.